Hello, everyone. Welcome to today's Global Ground Rounds. My name is Aisha Siad, and I'll be your host for today. Before we start, I'd like to go over a few things. So this presentation is going to be recorded and uploaded to our YouTube channel, as well as Figure One. If you watch our videos on YouTube, please remember that there's an option of playback speed to adjust the speed of the presentation. And on Zoom, you can turn on closed captioning during the presentation to allow for subtitles. So I'm going to go ahead and introduce one of our speakers, Melissa Kruetz. Melissa was born and raised in Southern California. She graduated with a degree in biopsychology, cognition, and neuroscience from the University of Michigan, where she was a student athlete as a member of the women's soccer team. Melissa is passionate about serving the military community as her brother served in the United States Marine Corps. Additionally, she is deeply passionate about serving the disabled community. Before entering medical school, she collaborated with researchers at California State University, Northridge, to explore the challenges that historically marginalized populations encountered when accessing services for children with developmental disabilities. Presently, as a student leader at Thrive Adaptive, she provides medical assistance at adaptive sporting events and advocates for improved care for individuals with disabilities among clinical professionals. Melissa is currently in her third year of medical school at Western U of Health Sciences in Pomona, California, and she hopes to pursue a residency in neurology. Also, fun fact, she studied American Sign Language for 5 years.
Okay, great. Thank you. So good morning. My presentation today, I know you kind of heard a little bit of my background in supporting the disability community. So I'm taking a look at it of how telehealth can help support and optimize services for this community. And on this first slide, I just wanted to include a lot of pictures that kind of depict that disability really looks like a lot of different things. So you can have, prosthetics, you can be in a wheelchair. These people are using sign language, they're deaf, blind, sometimes like Down syndrome or intellectual disabilities. So it really is a wide branching community. And then I just wanted to jump into the definition from the Americans with Disabilities Act of what a disability is. So a person with a disability is someone who has a physical or mental impairment that substantially limits one or more major life activities. They can also have a history of such impairment if they have cancer and they're in remission, or they are perceived by others of having this impairment. So someone who has scars from a severe burn. And then I would just break down what substantially limits. It was kind of meant to be interpreted broadly, so it's not this very strict standard. And major life events or activities are things that you do every day. So anything from eating, sleeping, walking, your cognitive functions, thinking, seeing, hearing, your ability to work, read, learn, communicate, your bodily functions. So it really is, this is also a broad range, but just so we have understanding of what disability is. And then we're going to jump straight into a case example. So this is obviously a made-up name, but Jackson Smith. So he is a 28-year-old male with a spinal cord injury at T10. And this is from a motorcycle accident 6 years ago. And he's here for a routine appointment to manage this chronic condition. You see him, he uses his upper body to transport himself from his wheelchair to the exam table. And he's also apologizing for being late because he must depend on a transportation service to get to appointments, but unfortunately, this service is typically unreliable and often late. What she expresses to you is really frustrating because it makes it really difficult for him to go out and even have the motivation to want to go out of the house. He has a home health nurse that comes to his house daily to assist with his care. And he expresses to you that lately he's been feeling some increasing sadness and he's missing out on doing some of the things he used to do before his injury, like sports and just being able to engage with others in his community. So next, we're just going to take a look at kind of past medical history. So oftentimes individuals with spinal cord injuries will have different comorbidities, and we'll talk about a few of them here in this example. So he has neuropathic pain and spasticity, and so for that, he's taking pregabalin and baclofen. He also has dyslipidemia, so his LDL is elevated. He's currently taking atorvastatin, and he's been encouraged to participate in some adaptive physical activity. He's pre-diabetic, so his A1C is 6. And again, just kind of encouraging him to take part in activities. And this dyslipidemia and prediabetes or diabetes is something that's commonly seen within individuals if they're not being active, obviously if they're limited by whatever that disability is. And then he has depression, so he's taking duloxetine. And then he has some pressure wounds, particularly on bilateral heels, and those he's just getting daily dressing changes. And then he has urinary and GI dysfunction. So he's often having some urinary incontinence, but for that, he's taking oxybutynin, and he's also doing intermittent catheterization. He also has constipation, and for that, he's taking Miralax, and he's increasing his fiber in his diet. So these are some common things that you would see with someone with a spinal cord injury. So now we're going to kind of dive a little bit more into his history. So review of systems, we're asking him respiratory-wise. He denies having difficulty breathing or clearing secretions, and sometimes people, if they have maybe a higher up spinal cord injury, those muscles for breathing are sometimes impacted. So that's always something we want to ask about. Musculoskeletal wise, he does admit that he's noticing some more muscle atrophy in his bilateral legs, so makes sense if you're not using them. And then psych, because he's kind of expressing these feelings of sadness, we just want to always check in. He says he denies thoughts of harming self or others. Social history, he denies using alcohol, tobacco, or recreational drugs. Currently, he's unemployed, and prior to his injury, he loved playing sports, especially surfing. And he had a community of friends through sports. And he said one day he tried to go to the beach, but his wheelchair couldn't go on the sand. And so he feels like he can't enjoy the same things that he used to. And that's like adding to all of these feelings of depression and sadness that he's experiencing. We go into some family history. So his dad just has some hypertension that's managed. His mom's healthy, no allergies, and no past surgical physical exam. So vital signs look good. In general, he's no apparent distress. You do notice that atrophy in his legs, and you notice it a little bit in his lower abdomen. Cardiovascular-wise, his pulses, dorsalis pedis, and radial pulses are 2 out of 3. Heart sounds good. Respiratory-wise, we're not hearing any wheezes or crackles. It sounds clear. Neuro, we do notice that he doesn't have sensation from pretty much below the umbilicus to his toes bilaterally. And then his patella reflex is actually increased, so it's a 3 out of 4. And then we notice that we find the Babinski reflex on both feet. And then we look and we do see those bilateral pressure wounds on his posterior ankles. We do a GI exam. His abdomen's non-distended. We don't see any scars or bruises, and he's non-tender to palpation throughout. So next, let's see, what do we do next, and how can we use telemed to help our patient in this situation? So I put down some considerations of using telehealth or how it can help. So telehealth, I think, is something that can help empower individuals with disabilities to be independent. And this is really crucial when it's something that's chronic like this, where it can really help them just have an improved quality of life and help with their coping skills, because sometimes they have to be dependent on other people for certain reasons. But the more that we can help them, just be self-advocates and be as independent and have the best quality of life, that's ultimately our goal. And then the disability community has specific needs that require more healthcare visits than people without. So I think using telehealth is actually great because they, in general, are just going to have a higher demand for it. And then we also need to think about how we can make telehealth accessible, because there's different needs. So if people are deaf or hard of hearing, blind, intellectually disabled, we have to think about how we can make the platform accessible for them. And I think that's something that we want to ask each individual patient, is how we can make it most accessible to them, because I think, just don't be afraid to ask. And then people with disabilities are more likely to live at or below the poverty line. So we have to understand that this might impact their likelihood to own a computer or phone or have internet access. So something we want to be aware of. I know there's a lot of resources out there that we can supply them to help with getting these things. And then in the disability community, mental health conditions are common. So, or they might have individuals with different behavioral needs. So if they need like group therapies where they're learning like social skills or they're learning life skills. I know like when I was working prior to med school, a lot of individuals with intellectual or developmental disabilities, sometimes those were a lot of the supports that they needed, or if they need speech therapy or there's a lot of actual like resources that they need, and sometimes that can be a busy schedule. But so if they need those, or like we're just saying, sometimes it can be really hard on your mental health because it's this huge change in your life and you're not getting to do the same things that you were able to do. And there's some feelings of loss. And so I think mental health is something that if we can help support it, especially with something like telehealth, where we can bring it to them, and it's also not something that they have to worry about like getting transportation for, I think would be really great. So we'll go through kind of the plan for him. So we'll order the basic labs and imaging. We want to just get a CMP, CBC, A1C, and then another thing to consider with individuals who are not weight bearing is that they might like lose some of their bone density. So we want to make sure we're getting a DEXA scan. And then something we can do is we can share resources with this patient about adaptive sports organizations, because not only is this going to help, strengthen his muscles and help with all those other like comorbidities that we're talking about with the like dyslipidemia and the prediabetes, but we're now providing him a community, and this will help like support his quality of life, because ultimately like that's our goal. Like we want them to be living whatever life they want to live and how we can support that. So can we help him get a wheelchair that might be more accessible, where it can have like a modality where it can go on sand, or just different things that we can help them? Because I think one of the things that I've observed in my experiences is that sometimes the health perspective is like we do basically the minimum for them to be alive or surviving, so like to get around their house, but then that doesn't always optimize what adaptations we need to help them live the life they want or do the things they want. So they shouldn't be limited. So as healthcare providers, I think it's really important that we understand that and we do what we can to help them live that life. And then I think we want to offer future visits to be done through telehealth, ensuring to ask and consider how we can best meet the specific needs of the patient. And in this sense, I think it would be really good if we know he already has a home health nurse coming, we can have them maybe help us with doing some more of a physical exam or assessing for things like pressure wounds, so that, maybe if that might be something that's harder to do over telehealth, we still have someone there that we can just communicate and have a partnership with. And then I think we go ahead and we tell them we'll have a follow-up in 2 weeks through telehealth and try it out and just see how that goes. And then this is actually some pictures from a group that does adaptive surfing. And so you can see that they have like the surfboard here where you have some things for them to hold on to, and then a group of people help pull the board out and then help them like push them, propel them with fins to get them riding on the wave. And then this is an example on the bottom of what the wheelchair can look like that can go on the sand. And so you can still be out there and do the things that they love. And then last thing, just talking about some considerations with culture and disability. So like one of the things that's always important to like always ask, don't assume, which is pretty much anything I think in life, but this is an example of where you can apply it. Some people prefer to be spoken to with person first language, so saying a person with autism, but some people really see their disability as a source of pride, so they would prefer to be called an autistic man. So always best to just ask what they prefer. And it's good to also understand that some communities within the disability community, like the deaf culture, have their own language and their own community. And so sometimes these groups can be very secular. So it's just important to understand that and respect it. And then consider how the medical model might come across as trying to fix something that's broken. But this conveys the idea that a person is broken because they have a disability. So I know that's something I think it's universal with any disability, but especially I think the deaf culture is very strongly like against like cochlear implant, because they're trying to say like from their perspective, they think that being deaf isn't anything that's broken, it's just different. But then when you have a doctor that's coming up and saying like, oh, well, let's fix this, like you can't hear, so we need to be like everyone else in the hearing community, so let's give you this cochlear implant to help. So just understanding like sometimes how things can come across and making sure that we're respectful and, understanding of what different cultures perceive things as. And then I think it's also important to understand that we want to promote inclusion whenever and wherever. So even the idea of adaptive sports, it's not so much about like creating a separate arena almost for like individuals with disabilities, but it's about including like everyone, so people with disabilities, people without disabilities, and how we can just, because that's also just going to enhance like community, or how we can incorporate, like I know there used to be, or sometimes I don't know exactly in the school system if there's still separate classrooms for like special needs versus the core group that's going through. So I think, promoting inclusion where we can have like an environment that's adaptive to the needs of different individuals, but also promote that, we're all going through it together. And so I think wherever you can do that is great. And then understand that some cultures might not be accepting of a disability. So some individuals or families might struggle with this. And so that's something to be aware of, because a parent could bring a child in and maybe feel some guilt or shame of whatever their culture looks at disability as. So that's something else just to be aware of. And I think it's important to know that the disability community is traditionally underserved and marginalized. So like, just historically, they haven't always had the best, relationship with healthcare and just in society. So it's something that we need to be aware of and culturally competent. And then, yeah, that's the end of my presentation. So if anyone has any questions or discussion, then let me know.
All right, so I see one in the chat from Dr. Pecchia. For labs and imaging, could these services also be brought to this patient's home and bedside to continue to address his access issues?
Yeah, that's something we talked about with one of the newer devices. I think it was called the Piccolo, where you can get blood from home, or even if we can have like his home health nurse draw blood. I don't know too much about how a DEXA scan can be done remotely like that, but I think some of the other core tests that we talked about can definitely be done at home and just reduce that barrier of him needing to get transportation to a place.
Do you have any more questions?
Yes, I have a simple question. Is it okay? Can you hear me? Okay, yes. So my question is, do you do kind of rehabilitation? Like, do you do rehabilitation program for those people with such disabilities? And so how do you incorporate them into the community? So, and how do such people join into the program? So like, do you have a special way of identifying them from the community and then you enroll them, you do rehabilitation? So how do you basically incorporate them into the program? Thank you.
So at least what I do, I don't work directly with like the rehab centers, but typically I think these patients would also have like a PMNR, so physical medicine and rehab doctor, that specifically would be in charge of kind of those roles. But I know, at least in terms of like the inclusion aspect of like incorporating them with the community, like at the events, like the adaptive sporting events, it's very much encouraged for like anyone to play. So like I've even joined in where we're playing like wheelchair basketball, and they say just grab they typically have extra wheelchairs there. So they say just like get in a chair and like join in on the game with us. So the community is very welcoming too. So I think, at least, I don't know if I answered your question correctly, but in terms of incorporating with the community, that's at least how I've seen it done.
And I see a question from Katherine. Where can providers find local resources, for example, the adaptive sports that you mentioned?
Yeah, so I think there's a lot. So one of the things, there's like things called regional centers where they kind of help families with children and getting them connected to resources. And that's kind of where like the state helps provide funding for all of these different like support services they need. So whether that's through them directly, or if you, like, I know like when I was working at CSUN, we had like a resource center. So you can kind of just like look into maybe your local like community, or I'm sure like all of our resource centers are connected with regional centers. So that's one way to kind of just, if we as healthcare providers can get that number, get that contact information to then give to patients, I think that helps overcome some barriers. And they usually have like a lot of the resources in one place. So yeah, definitely would recommend that.
This isn't a question, but more like a comment. I have a nephew who has autism, and what you were saying about inclusion, I think, is very valuable, not just like in the medical space, but also like education, for example. I think you were mentioning how a lot of times they'd have like different separate like special ed courses for students, and I feel like it should be more inclusive and have, everyone in the same classroom, or have people or have the students do more activities together, because it feels very isolating for people with disabilities. And I'm just very happy that you mentioned that. Thank you.
Yeah, of course. Yeah, there's so many, I think, areas where we don't always think of it at first, but I think just the more that we can promote it wherever. Like this is just like one example within education, but I really think anywhere in society, the more that we can promote it is better. Well, thank you guys. I will now let Katherine take over if there's no more questions.
Okay, so our next speaker, Katherine Quaraishi-Knobloch, is a native of Washington, D.C. area. But after high school, she was awarded an Army military scholarship at UCLA and moved to the West Coast. She pursued a degree in biology and a minor in Arabic. After graduation, she worked in the Medical Service Corps and served as a medical logistics officer and a patient administrator. Katherine is currently in her third year of medical school at Western University of Health Sciences in Pomona, California, on a military scholarship. She hopes to pursue a residency in family medicine, and fun fact, she has never broken a bone. And hopefully she hopes not to jinx herself.
Yeah, hopefully. Everyone should knock on wood. Okay, thank you everyone for having me. My presentation is on how we can empower primary care and bridge the gaps for genetic testing in rural communities or isolated communities that may not have access to genetic testing, geneticists, or genetic counselors. During this presentation, I will be mentioning multiple genetic testing companies, but I have no financial interest in any of these companies. They're just there to serve as an example. So I'll start with a very brief case to just start the stage of a very common patient experience, and then we'll go over the results. And then we'll go over the current situation in the world of the distribution of where genetic testing is done, majority where the genetic counselors are, and then talk about the new technology that is out there. So we have an 18-year-old female. She is 5'9", 130 pounds. And she presents to her family care provider because she's just had this ongoing pain, fatigue. It's kind of this dull pain. She also just bruises easily, but she's really active in high school. She's athletic, about to graduate. She dances. She's very flexible, does gymnastics. And she lives in a rural state in the United States, Idaho. And her family, her mom and dad, are uninsured. And she just turned 18. And her Medicaid insurance just lapsed. So that's the gap insurance to help children get access to health care. Her family history, her mother has depression, body pain, but brother and father have no similar symptoms. She also has sprained her ankle 4 times. She has depression and anxiety, and she's never had any surgeries. So the family care provider was thinking maybe Ehlers-Danlos syndrome. It is a very common genetic disorder. And he was thinking more the hypermobility just because of the easy bruising. She was very flexible. She was a dancer, so he didn't know if maybe that was just from stretching and dancing. But he decided to do the Beighton scoring system. So this is how you can clinically diagnose the hypermobility form of Ehlers-Danlos syndrome. And this is how you do the physical exam here. There's certain maneuvers that you do, but any physician can do these certain maneuvers. And literature has suggested that maybe a score of 5 out of 9 for kids is a good cutoff to make sure you don't have too many false positives. So this patient got a 4 out of 9. So some literature states that a 4 out of 9 can clinically diagnose the hypermobility form of EDS. Others prefer a higher cutoff. And then she also had some skin laxity and 2 bruises. So this provider didn't feel too comfortable clinically diagnosing her with her hypermobility form of EDS. So he decides to do a referral to genetics. So the closest geneticist is 1 state away, so about 6 hours away. And this was a pediatric geneticist, but he couldn't find any adult geneticists. And this referral was denied for a couple of reasons. One, the patient was technically an adult in the United States, and this institution liked to focus its resources on pediatric genetic cases, with few exceptions to adult cases. Another one is they were saying that there was a huge influx of Ehlers-Danlos syndrome, and they generally don't like to see those cases. So they just prioritize different presentations instead of seeing patients with EDS. This physician knew a genetic counselor, and he just did kind of a curbside, what would you do in this scenario? And the genetic counselor informally presented him as family care provider with Invitae, which is a genetic testing company based in the United States. and suggested maybe doing a connective tissue disorders panel. So this panel encompasses 92 genes, 92 of the most common genes that may cause a connective tissue disorder, seen with maybe skin laxity, hyperextensibility, which she had. So this patient did not have insurance. They were still working on getting her covered, but he saw that the self-pay option was $250 US. After the family discussed, because both the patient and the mom had similar symptoms, the family decided just to proceed with the cash pay price of $250. And her results showed that she had a mutation in the COL5A1 gene. So that's for the collagen type 5 gene. And this actually is for classical EDS. So it wasn't actually the hypermobility form of EDS. Right now, hypermobility EDS does not have any mutation identified at this time. And Invitae mentions that now that the proband has a diagnosis, family members who are presenting with similar symptoms can actually get tested for free. So up to 3 family members can be added on to the testing for free. So this patient's barriers were lapse in insurance, denied genetics referral, and then location isolation as well. And so here's the situation with genetics worldwide. So this is a look kind of at Europe. And this is the number of genetic consultants per million. They only included the geneticists that were clinical geneticists at this time, so not ones that were focused on research. And for example, in the Czech Republic, they mentioned that a lot of the geneticists are working in the private research sector as opposed to the clinical sector, so they excluded those providers. And then in France, there's many specialist genetics providers. So only genetics providers that specialize in like a couple of presentations that they like to see. So those providers were also excluded. So you can see that there's a range in how many genetic consultants are there. That includes geneticists and genetic counselors. So we have Ireland all the way up to Finland, about how many per million there are for resources. This is a look at the number of genetic counselors and what year the training program was established, and then how many genetic counselors there are. So there's a wide range in years of programs established, ranging from, looks like 1969 all the way up to about 2008. You can see there's a really big gap in how many genetic counselors there are to have resources with. And this is important to note, especially with the rise in direct-to-consumer genetic testing. For example, I think 23andMe is very popular, but testing that patients themselves can just order if they're interested. And when patients get those results, a lot of times they need some help interpreting those results because they ordered the result themselves, but now they're stuck with a result where they don't really know the significance of the result, which can be very stressful. And then in the United States, this is the distribution. So the top in the red is how many full-time equivalents they have, and then the bottom is the vacancies. So you can see that there are a lot of vacancies and a lot of institutions that are hiring geneticists. So there is a big need for more geneticists. The rise in need for geneticists both is because technology is now identifying more genes and mutations. 2 is that the direct consumer, they need more people helping to interpret the results, because interpreting a result is very time intensive. What is a benign variant versus a variant of uncertain significance versus a pathologic variant? So this is the United States. So where does primary care fall? Primary care is often the first one that sees the patient. And they see the patient, and oftentimes they see a family member, which can be very helpful. If you see a patient and you're doing a physical exam, and you're looking at their facial features and you're thinking, this is a very unique facial feature. I can't put a finger on it, but maybe it's the philtrum, maybe it's how their eyes, maybe it's how their ears are set. But you often kind of start to get a suspicion if something is kind of just unusual with the facial features. You're also able to get a really detailed family history, which can help build a pedigree. So that's how you can see kind of the inheritance. At the same time, you can kind of decide if this patient is a good candidate for genetic testing. So genetic testing and primary care ordering is very stressful for 2 reasons. At least in the United States, if you order genetic testing, there's the GINA law, which is the Genetics Information Non-Discriminatory Act, meaning that they're protected to keep health insurance, but this test result does not exclude any discrimination with respect to life insurance and some other insurances. So getting informed consent on what may happen with the result can be very stressful for a primary care provider to order. And then which tests to order. I mean, there's so many genetic tests that you don't want to misuse resources. It's pretty standard that if a patient presents with intellectual disability, the chromosomal microarray is generally the first test, but that's very stressful because these are expensive tests. Like, is this the best test to order? So it's nice to have that genetic counselor, the geneticist, to help guide your selection. And primary care also falls into, based on what you see, how do you alter the screening recommendations? For example, for Beck-Wiedemann, you screen for Wilms tumor up until age 10 because the presentation is in pediatrics, younger age for Wilms tumor. For example, if you have a patient that has a first-degree relative with both ovarian or breast cancer, maybe talking about a BRCA1 testing. So here are the barriers that were outlined in 2022. So there's a lot of barriers that we discussed. So our patient had patient barriers, including insurance concerns, social concerns like health insurance. Then we had kind of provider barriers. Without him discussing with the genetic counselor, he wouldn't know how to proceed with which testing is appropriate for this patient. A lot of primary care providers don't get a lot of training in genetics, and so it then can be really hard on how to interpret the results. And then the system barriers, he had a denied referral. So he did have an institution he could refer to in another state, but then that institution denied that referral. So where does technology stand right now? And what is a way that primary care can start using the technology at hand to help with diagnosis and test selection? So these are a lot of different genetic testing companies. So MyoGenes is based in the United Kingdom. And then we have GenePath, which is based in Australia. And then Invitae and GeneDx are both United States companies. Mm-hmm. But I bring up these examples because there's plenty more distributed throughout the world, including India. But all of these kits kind of look like this. So they generally come with a mailing packet. That's a prepaid mailing packet. It comes with how you're going to collect the sample. So some genetic tests, you can use a buccal swab, so just the cheek swab. Others do require a whole blood sample, but everything in this kit has what you need, including the test tubes and which color top it needs. So they're pretty nice. And a lot of these companies, they ship them directly to the patient. So it's not as if they ship to your office and then you need to send it out. They ship directly to the patient. And for the whole blood test, it's like kind of Melissa was mentioning with the needleless and how to draw. So this is just one of the many needleless devices that are available right now. So this works from suction, and you push this button. So you put it on. It has a long instructional video, but I'm not going to play it for you. But you put it on your skin. There's a button and there's a test tube. So right now the test kits like GeneDx, MyoGenes, they don't have something like this in the kit. Right now, the patient has to go get a blood draw and then mail the blood elsewhere or their buccal swab elsewhere. This is just one way that maybe if the genetic testing companies work with a company like this, that they can work together to make it even easier for patients who don't have access to blood draw centers. Another thing that anybody can download right now on their phone, this is a free application, and it's called Face2Gene. So a lot of genetic disorders have very distinct faces, either major or minor anomalies in facial dysmorphology. So anyone can download this app. And if you're kind of thinking, am I seeing something, am I remembering, a presentation? You can take a picture of the patient, and it actually gives you the probability of maybe what phenotype it's matching. So of course, this isn't a diagnosis, but it kind of gives you an idea of where to start. So when you do, if you do need expert advice with a geneticist, you can, in your referral, put, concern for Noonan syndrome due to X, Y, and Z, which can be very helpful when a geneticist gets the referral to kind of have an idea of what you're thinking. And then the last thing is eConsult. So Canada did a pilot program between 2013 and 2016 on linking primary care providers with an e-consult service with the geneticists. So this is where the geneticists could just reach out to the e-consult system. The geneticists were paid their prorated amount for each referral that they looked at. But this is a way that the primary care provider could talk directly to the geneticist to see, is this a good referral? Is this a bad referral? Or what are the next steps? So 83% were adult referrals, meaning that a lot of the referrals are adults. Maybe that's because they have a family member that got a new diagnosis. It could be the direct-to-consumer testing. It could be that pediatric genetics just has more. They have easier access to genetics, oftentimes because on presentation, there's a concern with just how they're presenting at birth. And so the hospitals have a built-in system to have access to genetics or do a rapid whole genome sequencing. Whereas adults, they might kind of slip through the cracks in teenage years, and then, they're 20 and you think that maybe they have something, maybe it's Fragile X, maybe they need a chromosome microarray. So maybe that's another reason why 83% are adult patients. So the turnaround time in Canada was about 2 days for an asynchronous referral discussion. So the primary care provider would add in all the information, they would do a photo, and then the geneticist would then respond with their recommendations. So about 2 business days, which is really an excellent turnaround time for a specialist care like genetics. And overall, about 30% were appropriate referrals and 70% were inappropriate referrals. So just utilizing a system like this can really take the strain off of the limited number of resources when it comes to genetics. And that concludes my presentation.
All right, I see some questions from Dr. Pecchia. How might virtual care availability in the primary care setting facilitate access to affordable genetic testing, genetic counseling, and ongoing screening and care for patients suspected of inherited disorders such as the ones that are presented today? And does the Canadian e-consult service effectively address the access and cost barriers?
Yeah, so Canada's health system is built differently than the United States. The United States right now is built mostly on a private insurance, where Canada, this was included in their funded insurance. So none of this cost was transferred to the patient in Canada. It's just that the geneticists themselves were getting a compensation for doing extra referrals in this pilot program. And then with respect to affordable genetic testing, the cost actually has come down quite significantly. So right now, a whole exome sequencing, the cheapest that I know of is about $2,000 for a whole exome. And then a whole genome, I think, was about $4,000. I'm not saying this is affordable, but the cost has come down. If you think about the scale of when the first genome was sequenced and the turnaround time. So cost has come down. The gene panels at GeneDx are $250. And that's self-pay. These companies generally have their own pre-authorization department that they'll do themselves to take some of the work off of the primary care providers. So if you're concerned about that, I would just recommend maybe reaching out, looking in your area, which genetic test, or looking in your country, which genetic testing kind of holds, is most available, and then calling the customer service and seeing, like, do you offer pre-authorization support? Do you offer genetic counseling support if we get a test? So that can be very helpful. And a lot of them have good cash pay or coupons or kind of payment plans as well, I've seen.
And if genetic counseling access is limited and or not affordable, might less expensive and more accessible AI analysis of genetic testing and exam results play a role in the near future?
I definitely could see AI helping with respect to the probability, like what is the probability or the inheritance pattern, and kind of coaching through that. Because a lot of the genetic tests, a lot of what people want to know is, am I going to pass this down to a family member? Is this a de novo mutation, or is this like an autosomal dominant? So questions like that, I think that AI could definitely take a lot of the burden off, because geneticists and genetic counselors, they just are trained so well in statistics and counseling and informed consent. So I definitely could see AI helping with that.
Okay. I have a simple one.
Yes.
Can you hear me? Yes. Okay. Mine is, the first is, I have both a comment and a question. So let me begin with the comment. I think partly the reason why geneticists are few, we can also blame it on the cost of training, because most of them have to be trained in centers where they do actually genetic testing. So because there is already limitation of the testing equipment, so you can't train these people where there is no hands-on activity ongoing. So you can't train them purely on what? On theory. There should be a little bit of practicability. Then the other reason also, I think even the cost of the machines, some of these machines are very expensive. Like in my country, I don't think we have any genetic testing. Most of them would rely the one for Kenya, the Khan University, and South Africa. So basically those are the two countries I know in Africa that actually do genetic testing. So this can also be blamed on that, okay? Then the question is, how long does it take to get these results? Especially if you send a sample, so like the turnaround time. Otherwise, it was a beautiful presentation, and maybe by the way. So are you also in the Army, since you're being sponsored by the Army? It's a by the way question. Thank you.
So one of your questions was with respect to turnaround time. So a whole exome, whole genome, generally about 6 weeks. And the reason it takes so long is that you need both the patient's sample. You also need both maternal and paternal sample. So that coordination can be very hard, and processing it. And then it's more information as well. And when they give the results, they need to give if it's a variant of uncertain significance, if it's a pathological variant. So that takes a lot of effort to put that report together. It's a multi-page report. When it comes to the gene panels, like the connective tissue disorders panel that I mentioned, that result can be about 2 weeks, so a lot shorter. At least that's with Invitae, and then my experience at the University of Utah with the turnaround time. I don't know in other places of the world what their turnaround times look like. The second question, am I being sponsored by the military? I am. I am. They are paying for my medical school. So, and then was there another question? I think that was it. But I agree with your comment with respect to providers are trained with where you can do genetic testing, and that's very limited. Generally, it's at the really big academic centers who also have the PhD programs for the research. So I don't have any solution to that, unfortunately. But I do find that the Face2Gene, the app, the Face2Gene, it can be just a good thing to see, and then see if the symptoms match up with the patient. And maybe you can't give a molecular diagnosis at that time because of the genetic testing restraints, but maybe you can say, you are concerned about this, and give it to the patient back to see if they want to link up with resources to see, or as the provider, you can see what resources there are, for example, for Noonan syndrome, and what the screening, if you have a patient with Noonan syndrome, what you can do as the primary care provider.
Okay, maybe a little comment. I think also one of the reasons why people are also not really venturing much into genetic testing, some of them really, after investing all the $2,000, $4,000 into the knowing your genetic profile, then the next question will be, so what next? You get a point. So you realize some of these, after getting to know the genetic mutation and the genetic disease, the big question is some of them actually we can't do much for them. You get it? Like you just end on only knowing the disease and you end it there. So that's why most people be like, okay, now like us in Africa here, we depend more on clinical presentation. So when you realize someone has maybe basing on the clinical presentation, you associate it to a given genetic disease, what you want to do is you tell the patient you have so-and-so, maybe you have Albert's syndrome, and you just end it there and you tell them, ABC, and that's all. So you just keep counseling them, knowing very well that you can't do anything about it. So I think that could also be a factor affecting the genetic testing, and more specialists running into that, because they ask yourself, so what will I do for the patient after discovering their illness? Yeah, that's what I really wanted to add on.
Yeah, absolutely. Genetics is one of those, here's kind of the answer to why it's happening, but it's not a specialty where you follow annually, because once you're diagnosed, that's your diagnosis. That's the mutation you have. Some patients like to have it because it helps with prenatal testing and deciding if they want to move forward. But you're absolutely right. There are some syndromes that you want to change how often you do, like imaging for maybe an aortic dissection with respect to Marfan's or something like that. But you are absolutely right that, for some people, it's not, you're not able to have a diagnosis. And for some people, they just don't need to know. And for them, that comes in with kind of the informed consent of, do you want to move forward aggressively to find genetic testing or not? And many people are in that no, I'm okay camp. And I completely understand that.
All right, do we have any more questions? All right, then. I would like to thank both of our presenters. Thank you very much for just an amazing presentation today. Dr. Pecchia put in the chat, thank you all for your attendance and interest in today's programs and topics. And then also thank you, Anna Joseph from Figure One, for supporting new evolving cases and collaborations and continuing medical education strategies. So you can go ahead and join Figure One using the link that's in the chat. Figure One, you'll be able to get CME credit by looking at similar cases on the website. If you have any questions, go ahead and email Anna Joseph. Her email is in the chat as well. And feel free to share these Global Ground Rounds, the recorded ones and the current ones, for future sessions with your colleagues, as well as Global Offsite Care's mission and activities. With that is all. Thank you all very much.